Okay, there you are. So I am talking to you from Vermont in the United States. So the internet here is not as good as it is in where you are. I'm sure it's very poor. So there may be some delay. So I hope not, but please be patient. So I changed the title a little bit because I want to talk about the general principles of healthcare quality measurement, which will be directly relevant and applicable to infection control. And of course, I have no conflicts of interest to declare. I was asked to show the slide, so I have nothing for you to worry about. And I like to talk about four types of measurement. The one we'll focus on today, of course, is quality improvement measurement, measurement for improvement. But what quality improvement people don't do, I think, enough is to talk about measurement that is for judgment, for accountability, for payment, or for penalty. And in fact, that's the kind of measurement that preoccupies people who actually work in healthcare. We can talk about quality all we want, but many people feel they are being held accountable for performing in certain ways and will be judged. And I hope we'll have a few minutes to come back to that after we talk about quality improvement. Of course, we also want to have measures that the public can understand. Very often, we present our data in a way that patients, parents, families cannot understand and misinterpret. This is true even for the Centers for Disease Control and Prevention, or CDC, in the United States, which often presents infection data in ways that no parent can understand or use to inform their choices. And of course, we have measurement for research. I'm a health services researcher and epidemiologist, so I care about this. But in my own belief, really good, rigorous quality improvement programs and projects are a form of research. We sometimes don't want to admit that because we have to then get ethics approval, institutional review, and so forth. But in fact, really good quality improvement, as you know, should be published and should be rigorous, and I think is a form of practical or applied research. But first, just some general principles. I hope that everything you do in quality improvement, infection prevention, has a causal theory, or as some people call it, a program theory. I'll say this over and over because it's something that I don't often hear clearly articulated. Here's the idea. If we have an outcome we want to achieve, and we think we can do X, Y, or Z to achieve that outcome, we have a theory. We have a theory if we do those things, those interventions, we'll have improvement in the outcome. Sometimes we talk about this as our degree of belief. I really believe that if I do these things, we'll reduce central line associated bloodstream infection. I believe if we do this, we'll have fewer urinary tract infection. Of course, those outcomes and everything done to improve them all require measurement. You can't possibly know whether you're achieving your goals if you don't measure. As you're trying to improve your outcomes, you will be doing experiments, very short-term, real-time experiments that, as you know, in quality improvement, we call Plan, Do, Study, Act, or PDSA cycles. And these also require measurement. I'll come back to that PDSA in a minute. I would prefer that when you talk to your clinical colleagues, nurses, physicians, and so forth, you call them experiments. There's no need to use some jargon, PDSA. It's just an experiment, the same kind of experiments I do in the laboratory when I was working on a vaccine for staphylococci. Now, in quality improvement, we often use what are called driver diagrams. And since I don't know you all well, I couldn't take for granted that you know about driver diagrams. So for those who know about this, I apologize. It's just to refresh your memory. So here's a driver diagram for controlling and reducing methicillin-resistant Staph aureus, which I'm sure you're all concerned about, along with the other very serious antibiotic resistance problems in Greece. And this is a driver diagram which reflects the theoretical causal pathway. Remember I said, excuse me, that you have a causal theory, and this is the visual expression of that. So here's the aim: reduce non-surgical MRSA infections, and I gave how much you're going to do it by, along with some balancing measure. A balancing measure are the unintended consequence of what you're doing. So if you're going to screen, let's say, for MRSA colonization, there's a lot of cost in that, right? The screening, the labor, the supplies, all that takes time, and we often minimize what the true costs are of undertaking an initiative. So, but there's the aim: to reduce these MRSA infections. And as best as I can tell, there are only two key drivers, key buckets of intervention packages. One of them is to prevent the transmission of MRSA in, let's say, an intensive care unit, so that patients aren't colonized as a result of being admitted to the unit. The second is to prevent infection itself. If a patient becomes colonized with MRSA, can we then prevent them from getting a clinical infection? So those are the two main drivers. If you can think of a third or fourth, let me know. I haven't been able to. And then we have what we call secondary drivers, or I think of them as major changes or intervention. We can screen patients to see if they're colonized with MRSA. We can use precautions, of course, to prevent spread. We can clean the room because staff survive well in the environment. Of course, we use dedicated equipment, and we wash our hands or use alcohol. And we, at least in the US, we use chlorhexidine washcloths to reduce the burden of staph on the skin and then reduce the likelihood of spreading it to another patient. You'll see that some of these drivers, or changes like hand hygiene, also prevent infection in a colonized patient. So if you are taking care of something in the groin and you go to the catheter, well, obviously that could cause an infection. The chlorhexidine also reduces the chances that the skin will inoculate the catheter, or for that matter, the ventilator. And then you have, of course, the bundles that we'll talk about in a minute for central line infections, for ventilators, and so forth. All of these, I want to point out to you, can be measured. That's the key. I haven't made the slide so complicated by putting on all of the measures, but what is the percentage of patients who are being appropriately screened for MRSA? What's the percentage of times that people perform hand hygiene? I know you're very keen on the WHO 5 moments. All I care is that really people do hand hygiene whenever it's appropriate, certainly on entering and leaving the room, and then the percent compliance with the bundles. So the basic concept here: visual diagram of the causal pathway, the main drivers and changes and interventions that you believe will actually reduce transmission and infection, and the measurement framework for that. Now, I talked about the PDSA improvement experiments. They're just experiments. You plan an experiment, you go and run the experiment, you analyze the result, and then you either adapt the intervention, or you discard it, or you go ahead and implement it. And all of that is just a prediction you have, and then you see whether or not your prediction was correct. And on this slide, I've shown ramps for each of the major drivers. Here's a ramp of Plan, Do, Study, Act, or experiments for hand hygiene here, for using the chlorhexidine, for the CLABSI bundle, for ventilator bundle. And why do you need to do these experiments? If it were easy to just say, do the central line bundle, just do it. Well, you know that wouldn't work very well. You have to perhaps do experiments about what you will put on a cart for the supplies for doing it. You have to experiment with a nurse reminding the physician, you've got to go ahead and use a big drape. All of these are little implementation experiments that are absolutely critical to make sure that when you roll out and start your program, there's a chance that it will be implemented the way you want it to be implemented. So I hope that's clear. Experiments along the key drivers of the causal theory that you have for reducing infection. Those are the quality improvement measures. And let's talk a little bit more about them. We have three I'd like to talk about. The first is Donovedian, and I'll review that. Maybe you know about this guy, Avidus Donovedian. The Kirkpatrick, here's the Don Kirkpatrick, and then I'll talk to you about a logic model that you can display your theory on. So just a refresher, and you probably all know this, Donovedian said there are three types of measure: structure, process, and outcome. Structure, things like the facility design, the number of infection preventions you have, the committees that you've set up. Processes are the key processes or practices that you think are really, really linked to the outcome of interest. So what do I mean by this? I know that if I'm going to control hypertension in Greece, and I've actually looked up the rate of hypertension in Greece in men, and I think it's something like only 40% or something are being screened. I can't remember the precise data, but if you've got to screen patients in order to treat them, and we know that if you screen and treat them, that's tightly linked to reducing blood pressure, lowering the rate of hypertension over time, and then to ultimately reduce myocardial infarction and stroke. So screening and treatment are process measures that you have to have in place in order to get to blood pressure control and reduce risk of long-term cardiovascular events. Some of my colleagues would call the reduction and treatment of high blood pressure as an intermediate outcome. I don't care if you call it a process measure or intermediate outcome, as long as you see it as a pathway from practice to better long-term outcomes. Process measures have many advantages. They occur every day. They're very frequent. There are a lot of them. You can measure them in real time. It's less practical to show that you reduce stroke, but that takes a long time. It doesn't lend itself to measurement during a quality improvement project. So process measures, you can do sampling, you can observe in real time, you can do audit on your rounds as you see the patients. They're really easy to measure as long as you believe, and in fact know from evidence, that the measures, the processes that you're monitoring are really related to and important in your long-term outcome improvement. Outcomes, of course, are the ultimate aim. Blood pressure control, as I said, could be an intermediate or short-term outcome, but the long-term outcome and impact is for myocardial infarction and stroke. Here's another kind of measurement I find very useful in quality improvement, the Kirkpatrick framework. This comes from the education discipline and from behavioral science. First of all, level one. What did the participants experience? So you are going to be part of collaboratives and other national and local initiatives, and you want to know that people had a good time, that they were engaged. If they're not engaged, they're not going to learn anything. You know, I wish I could see you all. I should turn on the camera of the room or something and see if you're sleeping. But if I'm not engaging you, then it's all going to fail. The second level is learning. Did you learn anything? And very often we simply do a little post-meeting test and say, you know, did Theo go go from knowing nothing about hand hygiene to knowing the 5 moments. Okay. So that's learning. Unfortunately, we don't make sure that people who have learned can actually do. We don't have them demonstrate, which would be a better check on whether they learn. The third is, did they change their behavior? Did they go back to their hospital in Salonika and actually, I don't know how you say in Greece. I always call it Salonika. But anyway, did they go back and actually improve hand hygiene? Did they go back and screen people better for hypertension? And that's level 3. Level 4 is the ultimate outcome. And most of quality improvement, I'm afraid, stops here. And we don't really monitor to see whether behavior has changed, especially over the long term, and whether outcomes are truly improved. So I love it when people say, that was a great meeting. I learned something. I'm transformed. But that doesn't really tell me if they've gone and acted. So learning should lead to action. Now, this is a little complicated. Most of my colleagues in infection control don't know what a logic model is. This is a more detailed display of your theory and what you're going to do to improve your outcomes. It starts with a context. So in Greece, the antimicrobial resistance rate, carbapenem resistance is very high, and we want to do something about it. And then you have inputs. The foundation gives some money to deal with antibiotic resistance. Then you have activities. This is an activity. I'm giving a lecture, or you may have more education and training. Very often, that's the focus of an improvement activity. It's not a very strong intervention, to tell you the truth. Education itself doesn't really do much. You'll forget 9/10 of what I'm saying. And then there are outputs of those activities and learning and so forth. Down here, just some assumptions and some factors, external factors. I understand you had a resignation of the head of the public health service. You probably didn't predict that. That may have some impact on what you're doing. And you can see this aligns with the Kirkpatrick framework. Here's the experience. Did you have a good time listening to Don Goldmann speak? Did you learn anything? The Kirkpatrick level 2. And then did you go and change anything? This is where I'm focusing right now. Did you improve the key process of care, such as blood pressure screening and treatment? And then here's Kirkpatrick level 4. Did you improve blood pressure control, and did ultimately hope to see a reduction in myocardial infarction and stroke? So I hope that's clear. That's a very quick run through. But I really like to see these because they show all of what you're planning to do and what you predict will happen. I want to go back to part of that logic model where we talked about the activities and the outputs. The outputs are really important. They're a core principle of the increasing infatuation, if you will, with implementation science as a separate science. I think it's all part of improvement, but some people are making their career on that. And I don't see it specified very often in quality improvement projects. So going back to the logic model, here are the activities, the trainings, the meetings, all of the hoopla and effort you put into it. And what are the outputs? What did you actually hope that would accomplish? When you invited me to speak, what were you hoping? Did you hope that I would change people's minds, or they would go back and all new knowledge and be much more effective? That probably won't happen, but it's important that you specify not just the learning objectives, but what you really hope will be the output of these major activities that you plan. And again, here's the Kirkpatrick model. Here we're in level 1, whether in fact you had the experience that will lead you to then learn something and change behavior and get better outcomes. Quality control, which we don't talk about much in improvement, is really necessary for sustaining the gains you make. It's necessary for the reliable, in other words, happens as a matter of routine, the reliable performance of systems over time and sustaining improvement. You can do it by sampling. You can do it by random audit of what's happening on the wards. If you're in blood banking, you do it all the time by probably regulation. I imagine in Greece as well. If you're in radiology, a sample of the readings are checked to make sure that the performance is as close to perfect as possible. It's really the cornerstone of patient safety in particular. I'm not going to go into these three bullets here. I hope that you're all familiar with these patient safety techniques that basically try to make a reliable system free of defects, free of mistakes over time, so that the outcomes will stay the way you want them to stay. Now, bundles you're probably familiar with, and I'm sure you're all working on CLABSI bundles and ventilator bundles and so forth. Just to be clear, these are small packages of highly leveraged evidence-based practices that when they're used together are supposed to improve outcomes. And I've listed just a few examples there. The key here is that it's not an endless number. It's not a change package of 20 different interventions, which I so often see. That's not a bundle. These are really key components of improvement that you think, if they're performed together, will improve outcomes. They're usually measured as all or nothing. Either you did all components or you didn't. From the point of view of a patient, they don't want partial bundle. They want all bundle. So all or nothing. But it's very important at the start to measure each component to see whether or not it's improving. If your all or nothing measure is not showing improvement, it may be because of one aspect. For example, large sterile drapes aren't available for the CLABSI bundle, and that's holding you back. So I always say start by measuring each component and then move to the all or nothing. I find that the most successful bundles are occurring in a very short period of time, such as the CLABSI insertion bundle for catheters. When bundles are involve a longer period of time, such as antimicrobial stewardship, it's much harder to monitor them and to get people to comply with them because they're stretched out. Antibiotic stewardship bundles in general, I find, are really resistant to all or nothing measure because they have too many steps. If everything took place at the antibiotic timeout at that one point in time, it would be easy. But you've got to choose the right antibiotic. You've got the timeout. You've got the adjustment. You've got how long does it go. It's a bigger challenge. And many bundles, as I said, are just too large and the components aren't well described. I just saw a paper actually that was in the journal Implementation Science Reports where they didn't define the CLABSI maintenance bundle in a way I've ever seen it defined before. And I couldn't therefore tell, is this any improvement or not? Because they weren't clear. Aggregate measures, and I know I have limited time, so I'm going to just go through these rather quickly. These are favored by national bodies and by boards of trustees of hospitals because they make an easy report that they can digest. But there are a lot of problems with them. For example, in the United States, we have something called the Patient Safety Indicator 90 that measures organizational safety. It's a combination of 10 components, each of which has its own issues. Some of them occur rarely, some of them are not well validated. And that's a problem for me. You have this aggregate measure that hides or obscures where improvement is needed, where there are validity problems, where one measure is getting much too much weight in the overall calculation. And people such as myself really don't like this measure, which has been imposed on institutions in the United States and is used to pay hospitals for the care they get. So really be careful about aggregate measures and be sure you understand their components and whether it makes sense to put them all together. And that brings me quickly to the judgment or accountability measures. Pay for performance, benchmarking to compare doctors or clinics or states or countries. Some people call these league tables because they look like the football rankings in Europe. The detection of people who are outliers and require the government to go in and examine them more carefully. These are the judgment measures that are so important in our daily lives as quality improvers and clinical people. In the United States, we give hospitals star ratings for quality and safety. 5 stars is considered a big deal. You can imagine that a star rating is full of problems. What does it really measure? Does it measure quality or just certain things that the government has decided are easy to measure? But that doesn't stop people from advertising. So here you go. Maimonides Medical Center in New York on the buses, #1 rated cardiac program in New York. So these are widely used in advertising and for payment and for prestige. But in my view, they're very problematic and have a lot of caveats and flaws. You've probably seen these. I hate these. These are the traffic light indicators that you often see presented to a, let's say, a board or the government. And it's either green, yellow, or red. Well, that doesn't tell you how bad or how good you really are. And it certainly doesn't tell you if you've been improving, staying the same, or getting worse. So I think these may be visually attractive and a good first look, but you have to be able to drill down to really understand each aspect of what these lights are telling you. There are a lot of problems with these. I'm going to not go into any great detail. You can look at these slides at your leisure, but I will say, look carefully. I have put here the sepsis measure in the United States. There are 2 components, and it's all or nothing. The things that have to be completed in 3 hours that make some sense: lactate level, blood cultures, giving prompt antibiotics, giving fluid. This is all pretty much common sense, but I'll tell you this, that you know that the data show that antibiotics have to be given within 1 to 2 hours to reduce mortality. So right away, there's a problem. And then there's a 6-hour bundle. And you can study this, but I can tell you that this is highly subjective, very burdensome and labor intensive, not supported by evidence. And in fact, some hospitals in the United States have an entire person, a full-time person, collecting data for this required measure, which I think is actually really tragic because we could be doing other things. So be really careful with these core measurements used for judgment. Be sure they're evidence-based and practical. And beware of targets. Sometimes the government will set targets for something, like in this case, the time a patient spends in the emergency room before they are triaged or admitted or sent home. And it was 4 hours was the target. And this hospital, the Mid-Staffordshire Trust, was top grade, 90-something% adherence to the national target. The only problem was they were killing people. There were increasing reporting of people dying as a result of inadequate care in the emergency department. And when the National Health Service went in and investigated at depth, it turned out there were many, many problems that were hidden because they were so focused on meeting the target. So set targets with great caution, and I'd be very careful about that. I'm not saying they're shouldn't be done, but they have to be done with your eyes wide open. And then there are other issues as well, but I'm going to stop. You can read the slide while I wrap up because I want to allow a few minutes for questions.